Good morning, everyone. My name is Ghaida. I'm a psychologist working in MHS in the inpatient and the outpatient setting. Today, I'm going to continue on the topic started by Dr. Amar in highlighting the facts and backgrounds of anxiety, more into the perspective and cases and psychological interventions. So, to kick the conversation, first, I would like just to disclose that I have no actual or potential conflict of interest. And I would like you guys to think truly. Do you think having or getting anxious is a normal feeling of human beings? You can write your answers in the chat. I'm not going to put a lot of pressure right now. So, do you think it's normal to feel anxious in some situations? Yes, of course. Lovely. All right, that was fast. Okay, right. So there is a continuum of an anxiety where it starts from mild or barely seen as an anxiety level. Those are the level of anxiety needed to, um, keep us safe or protect us from dangerous situations that immediately we run of the threat, or it can keep us excited and motivated to perform better and better. It gets a little bit uncomfortable sometimes when the stress is increasing, and it gets pathological when it's actually dysfunctioning our daily activity. So, as Dr. Omar already stated in his slides, there are clinical observations that we notice that we can self assess ourselves. Am I actually having an anxiety disorder? Or actually, I'm just having a mild anxiety? Or this is a situational anxiety where I can just manage it by myself? Yeah. So I believe the intensity of the anxiety, because there are some situation we feel mildly anxious and it's completely normal, and the same person themselves they can feel extremely. Oh, the slide is not showing. I can notice that. Just 1 minute. Okay, we go back. Yep, we're here. You can see it, everyone. Just thumbs up if you can. All right. So the 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 level of anxiety differs depends on the situation, and this actually can depends on how we perceive the threat. Right there, sometimes we overestimate the threats and we underestimate our abilities on handling these threats. We feel like we're incapable to manage them, and that's why there are situations that we can excel, we can manage it, and in another situation we just feel like it's too much on us. It's very overwhelming. So that doesn't make us anxious all the time, but it makes us walk into this continuum normally. And when it reaches the level every day, I'm not able actually to tackle or to work in small issues in life. There, when we need to look for further assessment, clinical assessment, if we are having any pathological anxiety at this time. There are normal common responses, and those responses, no, it's this slide, sorry. Okay, so there's one slide missing. It's fine, but I'm gonna ask you all, what are the common responses to an anxiety? Again, you can write it in the chat. So what are the common responses? How do we respond when we are under threat? Dr. Amr already mentioned two of them. First, increase heart rate and breathing. Sometimes we avoid situation, fight and flight. Yes. Okay. All right. Lovely. So the common responses of an anxiety, there are mainly five, and it depends about the situation. They're fight, flight, freeze, fawn, and flow. So I'm going to go briefly on examples of each one of them. The fight responses is when we get aggressive, right? We get like very agitated because of this fear and we just jump into the threat and try to fight it. The flight response is the most common one that everyone of us usually do is the avoidance. We run away from threats, right? And the freeze is when we are just feeling numb. We don't know what to do exactly. We feel like confused And the found is when we are trying to compromise, like we're feeling anxious, but we're trying to compromise by being gentle or giving the threats what they needed. I'll give you an example on found because it's very confusing. So the found response is actually when a manager is shouting at you, you get anxious. But instead of avoiding or running away or fighting back, you tend to compromise and try to having this lovely conversation. Usually you see this behaviors within children, right? When you yell at the child, they'll be like, "Mommy, do you want me to do some massage for you?" Right? But they're scared.
Dada, we lost your audio. We can't hear you at the moment. Still can't hear you. Still no sound, Gaida. You want to try to mute and unmute yourself, if that would help? I know you are together with Dr. Omer at Baid al Diafa. His connection worked great, so not sure what's happening at the moment. Right, I can see that Gaida dropped off. I'm sure she will sign back in, and inshallah it'll work.
Can you guys hear us here?
I can hear you loud and clear, but obviously we couldn't hear Gaida.
Yeah.
Did I lose connection?
Were you able to hear Dr. Ghaida while she was talking?
We heard up to a point when the child says, "Mommy, can I give you a massage?" And then we lost you.
Okay.
I'm sorry for that. Something went wrong in my internet here. So I'm gonna just sit beside we can maybe switch.
Yes, of course. Yeah.
All right.
There you go. We can hear and see now.
Okay. Perfect. All right. So the slide of the common responses is not there for some reason. It's all right. So I was explaining the five common responses: the fight, flight, freeze, found, and flow. So the found is where our the person is trying to compromise their fear by pleasing the threat, the source of threat. And that was the example of when a mother is shouting at her child, he's actually getting anxious and scared. But instead of running, he tends to compromise her and ask her what he can do for her to calm down, right? This is a very common situation that we see among children. And the flop one is the last one, is when it's very overwhelming to the extent that people lose sensation and consciousness and they just collapse. Commonly, when people are going through a very overwhelming news about loss of a loved person, they just don't comprehend it, at the moment, and they just collapse and they don't know what to do, right?
Gaida,
So,
can I
yeah,
briefly stop? Do you want me to share the slide that you can't show?
yes,
If
please, if you can do that, yes,
I've got it ready here, so if you just allow me to share my screen.
that's right. Yeah, it's all right. Yes, thank you, Miss Katia. This is the one.
Okay.
Yeah.
Yes. All right.
Okay.
So so then you can go ahead from your end, open, and then we'll let you know to go forward.
All right.
Okay, Miss
I'm
Katya?
happy to
Okay.
hand over back to you. I
Yes.
just thought that it might help people to visualize the
All right.
five
Yes.
areas to see this.
Yes.
So carry on, Gaida, and when you leave this slide, I'll hand back over to you if
I
it's
see.
Okay.
easier.
All right. Okay.
Okay.
All right. So in these five responses, again, we commonly can experience all of them, right? It depends about the intensity of the situation and the level of anxiety that we're experiencing at that time that could cause us to fly away or just to fight it back or just to collapse, right? So What are your common responses to danger? If you're feeling comfortable to write your answer, that will be perfect. Can we open the chat? I will just want to read the answers.
Something.
So how
Find
do you
the safety.
guys deal with anxiety? Do you fly? Right? Flight. I slow down, talk more slowly. Right. Right.
Okay.
Coping strategy. Now we're coming to the coping strategy. Those are techniques of our conscious brain to deal with an anxiety. But this involuntary functioning or responses are the common ones in every human. We tend to use them all, even if you're conscious and aware, and even if you're in the field, you tend actually to the faster track in our brain tends to send faster signals so we can take off if that danger is actually a lion in front of us. So later we're going to talk about the coping techniques and the strategies. Oh God, and we cannot control emotion. Lovely. Thank you for your answers. All right, we proceed. I believe the next slide. Um, yes,
Do
you
you
can
want
see
to
the
take
screen
over?
Yes.
Yeah, I think it's easier for you to. I'm just your backup here for any technical issues.
Okay.
So
Thank
I
you.
shall hand over to you
Yeah.
again,
Do
and
you
you can
see it?
share your screen.
Yeah. Do you see the slide now?
Not
Near
as yet.
bottom. Yeah. Amen.
Yeah.
Nothing yet. We are in this weird and wonderful era of technology. All
Yes.
sorts of things happen always.
One sec. We will just give us this one.
Mhm.
Uh, this one. Okay. This one. This one.
Yeah. All right. Apologies for this technical issues. All right. So we carry on a slide that you will see right now in your
We
screen.
can't see anything.
Now, can you see it?
Right now, can
No,
you
it's
see it?
not sharing yet.
Ah,
All right. Miss Katia, if you can open the last updated
I think
PowerPoint, it's all
no.
right. We can carry it from your side.
No, it's good.
Now it works. Yes.
Okay. All right.
All right. Okay.
There we go.
Yes.
All right, okay. So the neurobiology of an anxiety, Dr. Ahmed already explained it. I'm gonna have to explain it again in more easier and simpler way for people who are not more in the medical field, maybe perhaps. So think about our brain as the security system, and the amygdala is actually the smoke detector when there is a danger. It detects the danger and then it sends it immediately to the hippocampus.
Mm.
The hippocampus actually works as the photo album, all the memories, all the relevant situations where we either experience these situations or not. And then later on, they send it to the prefrontal cortex to make the decision, telling the prefrontal cortex, like, all right, we've been through this. I've been facing a spider before and I killed it. So the decision will be taken as not running and fight it again. Is that clear, Way? Do you have any question about that? Can we see the chat?
Mm-hmm. I think Miss Katia, if there is anything, she will let
Yeah.
us know, right?
Yes.
I will do. I will do.
Yes.
All right. Okay. Now let's move to the type of an anxiety, but in different ways. Dr. Omar already explained different type of an anxiety in the DSM-5. I'm going to talk about the acute type of an anxiety that we commonly see when we receive a call from patients relevant through AMS or the triaging team. Now they all look the same, right? They all look the same. It's very actually hard to differentiate if it's a panic attack, an anxiety attack, or situational anxiety. Once you ask the patient common questions, you will know if it's actually a situation anxiety, like did it only occur today? So they're definitely having an event that trigger that anxiety, and this is called situation anxiety. Usually, people face it in public speaking, having weddings, or going for a job interview. And as long as this trigger is there, is possessed there, that the anxiety will be there. And once they're being removed from that environment, they'll come back to normal. Now, an anxiety attack is more like the slow attack of panic attacks. It works slowly, right? You have these worries over time, age, years, and you develop those worries. You have this chronic stress as your behavior, as your personality traits, and it does occur in specific situation, which is likely to happen. Panic attacks are not expected. So you might discover that you're scared of spider all of a sudden, right? You might just experience being locked in an elevator and having a panic attack because you've never been locked. You never thought about it. But when you place in that situation, here when you collapse and you're having the panic attack, maybe this is how you would differentiate between each one of them. Why did I mention those ones? Because these are the acute and anxiety situations that we receive through the EMS or the triage, right? Moving forward, we have this is a clearer way to differentiate between them. So as I explained earlier, the situation anxiety actually is a problem that likely to happen, and it's manageable as long as that person is removed from that environment. The anxiety attack can be unexpected, but the person is already thinking it over and over, and it lasts longer than the panic attack, right? The panic attack starts all of a sudden. It's shorter and brief, and usually I think the maximum is 10 minutes, not more than that. And the fear that they sense losing control. So they be shivering and feeling that they're not in control, and that's why the breathing in that rhythm, fast rhythm. All right. So, but they're all actually sharing common symptoms: rapid heartbeats, shortness of breath, sweating, nausea, dizziness, chest pain, and discomfort. Right. Moving again to the factors of an anxiety. There are internal factors and external factors, and it's very important actually to know the factors behind the anxiety attacks. There are biological factors, like some variation in the genetics. It could be like people sometimes they have imbalances in their GABA system, and that's why they go through an anxiety attack or easily get anxious. Personality traits. There are some people that well regulated. They know how to regulate their emotions. What we call them as emotional intelligence people. And there are people who lack this emotional control, and that's why because of these traits, they're more prone to have an anxiety attacks. The cognitive processing, which is the very important part, the ability of a person to interpret a situation if it's a danger or not, and able to objectively assess it. The past experiences, right? The people, again, they've been through these experiences or relevant experiences that make them think this is a danger, and that's why they have an anxiety attack. While the external factors, there are factors that sometimes beyond our control, right? Things that we cannot change. Something like life stressors, losing a job, traumatic events. We can never anticipate having a traumatic abuse or event, right? Social pressure, like social factors, and environmental stressors like noises or any incidents that caused by the environment, right? Now, what we do in our we're moving, yeah, sorry for the delay. Now, what we do in our, we're, we're removing this slide. I'm sorry for that. Now, before we go for our CBT interventions and the techniques that we're using, I would like briefly to explain the formulation of an anxiety, how we deal with it in our clinics, right? Once we receive a patient with an anxiety, we start from the bottom all the way to the up, all the way to the top, sorry. So we see a patient going through physical symptoms. We ask them how they're feeling, and then we're asking them about the situation that triggered this feeling. And then again, we're asking them about their thoughts, what they're thinking about it. Are they in danger? Do they have like some automatic negative thoughts about it, right? And then later on, throughout the sessions, we come to the rooted issue where it started. And anxiety starts from early experiences in our life, right? This early experiences, not necessarily that we face it by ourselves. It could be experiences we observe from our parents, how they're handling anxious moments, right? Are they collapsing when they're receiving news? Are they shouting? And that's when we develop this core belief about anxiety that is not a pleasant feeling at all. And then later we come up with those rules that I should not put myself in situation X because I'll end up having, as my mommy had, a collapse or a breakdown or whatsoever. Those rules make us very rigid in handling um, intensity situation of an anxiety, right? So, but let's bring it back in more practical things that we do in the EMS or the triage. I would advise that we only focus on the situation and then asking what they're feeling about it, the situation, what they're thinking of it, how did they react, and what physical symptoms they're having. These important elements are very important for the acute anxiety that later on in the longer sessions, maybe we'll go more in depth. So nobody's expecting actually to go through the early experiences of the patient or modifying their core beliefs. Those are works that are actually more in the outpatient setting in longer therapy. So far, do you have any questions? Because we can't see the chat, so I think Ms. Kati can help us. Did
Yes,
anyone have any question?
Raj Kumar has posted here about what about GAD? The most of the cases from pre-hospital settings is anxiety due to loss of loved one, lack of sleep, aggravating chronic medical conditions, mostly due to pre-existing psychiatric conditions, family issues, work-related stress, loss of job. Every day we get at least 8 to 10 cases of abnormal behavior, mostly due to anxiety.
Correct.
And Rajkumar notes that most of the cases the clients refuse to talk and will say one or two words. So obviously that might make the assessment quite difficult.
Okay, right. Yes. Now, when a patient actually is going through a freeze moment, as we explained earlier, we're not expecting them actually to be able to interpret their thoughts or their emotions. They're still processing the shock, right? So what we do is actually maybe try to relax. Later on, I will explain how to make their nervous system a little bit relaxed so they can briefly describe what they've been through and what they want from us and how we can help them. Now, I will ask you, Ms. Katia, if you, I'm sorry for that, but if you can use the slide from your ends because those ones are not updated and it's better to let them see the coming slides.
Okay, just give me a second and I'll put it on the slideshow mode. Ah, this is the problem that you're having. Um, okay, so it won't show if I turn it into a slideshow. Oops, sorry. Let me change that. Wrong screen. But this way. Now can you see it?
Yes. Right.
Yes.
So we moved to the internal and external factors. So here where I'm answering Mr. Raj's question in the spectrum of an anxiety. Yes, mainly we see general generalized anxiety disorder. I think everybody can see the screen and
Maximized? Can you maximize it, Miss Katya? Yeah.
This is all I can do because if I click it on slideshow, it goes blank.
Oh,
right.
I think there's some sort of technical formatting thing with the slides, but this way it does show.
okay.
I'm just trying, I'm conscious that it shows the, all the text here as well.
No worries. All right.
Okay, no
We'll
problem.
work it out. All right. Okay. So we're moving to the slide where I'm answering the question of Mr. Raj of the spectrum of an anxiety disorder. Can we move to that slide? Yes.
Yes.
So yes, we do receive most of the cases because of during anxiety disorder or we loss and grief, but an anxiety is a common element in most of the mental illness disorders. The ways that we learn how to identify an anxiety and manage it, it will help us actually in all the rest of the disorders, like insomnia, eating disorder, autism, and ADHD. Most of them, they have reasons for them to be anxious, right? In eating disorder, for example, people feel anxious about their self-esteem, their appearance, and that's why they go through these eating disorders. But there is an anxiety there, right? ADHD, they definitely heard many comments about their lack of attention, and social context make them extra anxious because they wouldn't be performing as what other people expecting from them, right? So all the rest of the cases that we receive, regardless of what are the backgrounds or what are the reason of them to have this anxiety breakdowns and attacks, it's very important to learn how we walk through them, how we can help them, and then later on we can work on the root issues, right? Like, for example, grief will take its time. In the acute intervention, we're not expecting them to accept the grief they're going through, or they actually pay past it, or they just immediately feel good about it. But we want them to calm down. All what we want from our patient is to be able actually to not maximize those symptoms to more clinical significant or dangerous symptoms later. I, I hope I made my point clear. All right. So in the coming slide, we have the common techniques of the psychological interventions that we're using. Mainly right now, worldwide, CBT is the common approach that we're using and dealing with anxiety. But I would like to highlight a point here that when we're tailoring an intervention for a patient, it's not necessary that we're sticking to one approach. We're actually blending most of these techniques together, right? So we can sometimes having CBT and then using some techniques from acceptance therapy and using some techniques from relaxation techniques, right? I'm going to go briefly through them. The CBT, mainly the cognitive behavior therapy, relies on reconstructing the negative thoughts of the patients, right? And we do this through many techniques, reframing the thoughts, checking if it's a fact, see the probability, and try to find for and against evidence. And we work it with along with behavior activation because once we go into thought checking, it might be very anxious for a person telling them that this is actually not a threat. See, there is no for and against evidence for that. Those are not based on facts. So we try to cheer them up by engaging them in behavior activation, like pleasurable activity, like rewarding themselves, right? And throughout the conversation with them, we use Socratic questioning that will make them think deeply. Where did it come from? Why actually you're being able to handle other anxious moments, but you're not able to handle this situation? What happened? What interpretation that you have? And then later we have the mindfulness-based cognitive therapy is when we bring in their conscious into the present moment, here and now. Whether they want us to, whether we want them to notice how they're breathing, all right, like the rise and the fall of their chest, or we make them scan around them. This is how they're being mindful about things that are happening around them in the moment. Because when a person going through an anxiety attack, they're actually disconnected from the reality. They be very engaged in their internal thoughts. They be very worried, a thought after another, very racing thoughts. What we try to do is actually snap them out and tell them that be present at the moment. Notice what's around you, right? So we can disconnect the automatic thoughts. Yeah. In the acceptance therapy, we're trying to accept some external factors that we earlier said that it's out of our control, right? There are factors that we cannot change, loss of someone, loss of a job, relocating and adjustment issues, right? So we're trying to bring the radical acceptance a little bit to the surface, along with cognitive diffusion, right? So we're diffusing this thoughts by either labeling them, not labeling them, noting them without judgment, or you can actually write them down and just make them stay there in a journal without processing them. So that's how you can diffuse these thoughts. There are many other techniques. The exposure therapy is the one therapy that works with phobia. All right, so we start gradually by imaginary therapy. We bring picture of those spiders, we let them touch it, and then later trying to bring something like same texture of those spiders, same color of whatever they're feeding off. And then later on, if we got the chance, we can take them to actual in vivo exposure. Yeah. We need to be very, very careful using exposure therapy, as the patient could um, get elevated more and more and anxious more and more, and we go back to point zero. So what would I advise you to do is actually to notice how skillful they are with coping techniques first, if they can master the coping techniques, and then we go and try them along with the exposure therapy. Relaxation technique is the ones that are expected in the acute anxiety, right? Is the one that we use in the ambulances during the call when we're receiving a very agitated patient or anxious patient. We tell them to slow down their breathing, right? We tell them there are many techniques in breathing technique. As Dr. Omar explained, there are the box breathing, there are burst lip breathing, there are the coherent breathing, and there is actually other types of breathing. But what I would like to mention here is breathing technique is not one size fits all. You need to be mindful about that, because this is a common thing that we hear around, right? When people hear breathing technique and mindfulness techniques, they tend to use it with with every patient. And that's not a right solution, actually. We need to actually take the history if they're having any asthma, if they're having any medical issues. That actually can escalate the issue, and that can actually make it worse and worse. Yeah. So the breathing technique, there are, I will just mention three types or three categories. If we can move the slide, Ms. Katia. And I think the next slide is not showing as well. It's all right. I will mention it from here. So the breathing techniques, it's not there. It's all right. I don't know what's wrong with the slides today. I'm sorry for that. So for the breathing technique, I would advise, if you're receiving a patient going through a stressful moment or general anxiety, use the 4-7-8 breathing, right?
Mm,
Or use the normal breathing techniques, the diaphragmatic breathing, right?
mm,
If the patient is going through a panic attack, they mostly having hyperventilation. And that's why we need them to slow down their breathing, because they're breathing from their mouth. They're just inhaling a huge amount of air, and then they're exhaling very few amount of air, right? So to avoid this incident of fainting or going through rush breathing, we can extend the exhaling. So the longer they exhale, more than inhaling, and then the grounding with the breathing technique, right? Because they're rushed, they're breathing fast. So we try to tell them, can you just notice 5 things around us? Can you actually hear 4 things around us? Can you actually touch 3 objects and describe them around you? So what we try to do is actually, even if they're resisting, I want to tell you that when a person is going through a panic attack, their listening skills definitely is going down, right? They're blocked right now. They won't listen carefully. So repeat it gently over and over. If it didn't work from the first 2 times, we're not expecting breathing techniques actually to show effectiveness from the first 3 trials, right? So we go over them again and again until the person learns the right technique. The grounding helps the patient actually to face those thoughts and disconnect from these thoughts while he's breathing normally, right? So those mainly are the common techniques we're using in psychological interventions, right? We're jumping now to some do's and don'ts. Dr. Ahmed already highlighted some of them. I'll go through them briefly if we missed anyone. So yes, you need to stay calm as much as you can. There are patients, when they freak out, they become very aggressive because they think they're dying. Isn't that common, right? Isn't that normal? If I think that I'm going through a heart attack, I'll be very defensive. That's one of the common responses, right? I'll fight it. I'll fight the staff. I'll fight whoever around me. Like, take me to the hospital. Give me, and don't neglect me. Give me the attention that needed. So you need to be very calm with those kind of patients. Practice active listening. Do not jump to conclusion, right? The more that we're practicing those techniques and the more that we are in the field, we think that we know it all sometimes. And this is where we lose the patient, because we don't give them what they want because we're not listening actively. Offer instructions. Sometimes patients know what they want to do. Patients know their safety blanket. If they say, call my mother, call my father, just stay next to me, just tell me that I'm going to be all right, and it works with them, then do what they need, right? Assess their safety. This is an important thing that you need to know, that there is no health issues before practicing any of the advice techniques. Be empathic. It's a very stressful and overwhelming feeling that they're going through, right? It's very momental and it will go away, but we need to be empathic with them. Maintain professional boundaries. Now, some patient, their safety coping strategy could be inappropriate sometimes. You need actually to be professional by not actually crossing the boundaries, like hugging the patient perhaps, or saying inappropriate thing, even if that comforting the patient, right? The don'ts thing, the things that we should actually avoid completely, don't minimize their feeling. I know that we know all of us in anxiety is an acute sensation, yet we need actually to give full attention as if it's our first case for each patient, because that patient is their first, right? Don't use technical jargons, avoid these technical words, like don't tell the patient, all right, do some mindfulness technique, do some CBT techniques. They don't know what CBT. So guide them rather than instruct them. Do the breathing while you're doing it with them, instructing them. Do it with them, right? So breathe in, breathe out, and they will follow. Don't rush the interaction. Sometimes patients actually they just take a few moments and they'll be okay, and that's for the situation where you're maybe outside, right? Maybe you're let's not say you're out of duty, but you're observing a patient that's they're collapsing or they're having panic attack. Just don't run to help them immediately, because sometimes the patient actually just take a minute and two and they become to normal, they go back to normal, right? Because that would reinforce, if that patient is used for those panic attacks, for example, and he was trained to cope with them, but it takes them 1 and 2 minutes. The minute you intervene, you actually threaten them that, oh, that's a very terrifying situation and it's very dangerous. You would actually start to reinforce those panic attacks to reoccur over and over. Do not show your own anxiety. I know that there are sometimes very stressful for us actually when we see people are panicking, they're doing some abnormal things. But as much as we are trained, let's try to calm down ourselves, asking for supervision, guidance, support from colleagues around us if we believe that this is beyond our capability. It's completely normal, right? All right, and do not overpromise. Some people sometimes they share words, you're gonna be okay, I'm gonna bring you this and that. Yes, people, for example, they're having panic attacks in the inpatient because they're fought with their employer and they want to be going back home, all right? And we know that this is a process that will take time. We don't need to tell the patient, I'll send you back home tomorrow. I'll make sure that you're home around your family tomorrow. Do not overpromise the patients, right? Because again, they will collapse back and over and get agitated. So yeah, I'm actually done from this part. Before starting the real life scenarios, I would like to hear all your questions and comments.
There is nothing. I only commented in the chat about the 5 4 3 2 1 exercise. It's very, very effective. But there are no other questions or comments in the chat at the moment. Does anyone want to ask anything? Right, now we have from Raj Kumar. We are encouraging all the paramedics to do quick scene risk assessment. Patient is harm to self, paramedics or others. Quick mental status examination to rule out the risk and find out the severity of mental health condition if safe to do so. De-escalation techniques. If it does not work, escalation within services. Call for help, physical restraint or chemical restraint. That's Raj Kumar's comment.
Yes, that's very if you allow me to comment on that. It's a really good summary. And adding to that, I don't know if you mentioned that collateral information, it's a must to get from the family members. We do need that to be documented about what's happened, if it's first time, if any history of anxiety, any medication they're on already, medical condition, anything that would help us, to guide us how to approach in terms of management. That would be great. But I would like actually to before um yeah can you Katya can you just go can you close the slides? I want to see the I would like to ask you one of from the audience, if there was any interesting case they encountered and they had difficulties before we start the scenarios. Anyone had anything like that would like to share with us?
I think someone is opening the mic.
Yeah. So perhaps then I will ask Mr. Muhammad Adnan Adil Saeed. Mr. Muhammad Adnan, are you there?
Yes.
Yes. So, can you introduce yourself and if you can share with us any example of like where you had a challenging patient or something that perhaps you were able to handle, or you had some difficulties and you needed some help, so we can explore more about it, please.
I'm Muhammad Adnan working in EMS their facility SAS.
Nice meeting you. Yeah. So,
Mm.
did you encounter any patient with anxiety where you had to was very challenging for you?
And there is some patient while transferring from like and facility to another facility. They are
Mm,
like they have an anxiety from feeling if they have any surgery or if they have any medical appointment. So
yes.
they will have some anxiety that is like normal anxiety. So we'll try to talk with them and be assured that there is no issue and only it will be like a medical uh, um, like medical
Matter. It's medical
and matter,
matter.
and then
Mm,
it's not, yeah, like the specific thing we're doing is like we're trying always to be talk with the patient in like friendly and try to make them calm and no need to afraid,
mm.
especially if they have family. Also, we will try to explain everything for them.
How would you how have you dealt with any language barrier?
Sometimes, yeah, if like there is some nationalities they are not
Yeah,
talking Arabic or English. So
exactly.
this patient, yeah, we have some language barrier.
What would you do? It's
If
interesting because
like if my partner he can speak his language, there
mm,
is some patients like some nationalities they are not talking Arabic or English. If he have he
mm,
can translate for him, or sometime inside the hospital before the transfer.
mm,
We will look for a nurse or
yeah.
the assigned nurse to talk with him
Mm. Okay.
before transfer.
Do you guys use any translator like Google Translator, anything like that to translate sometimes?
For me, not always, sometimes,
Okay,
but
okay.
rarely.
Okay. It must be very hard. It's not easy, but I think sometimes, يعني what we do sometimes even in we I do encounter such a thing. Non-verbal like sign, it helps sometimes even to calm down the patients. By like giving, the peaceful face, like, you'll be fine, with your gesture, with your hand, things will be fine. Like, even if they don't understand, I think they will sense that you're trying to keep them safe. Thank you so much, Mr. Muhammad. Thank you.
Thank you.
Just
So,
a note, if I
yes.
may, there's a couple of things in the chat. First of all, Raj Kumar noted that he's reviewed many patient records as part of quality improvement. The lack of collateral info or not much info is one key challenge for
Mm,
EMS. And Hassan noted that the most challenging is that the patient has issue with husband or relative and he came back to home or he is present when we are there. The case will be difficult with the patient telling, I have shortness of breath, I can't breathe. And Rajkumar notes language barriers are often present. So any thoughts Dr. Omer Gaida, around a relative or husband where the conflict is? What would you guide?
For which one? I'm sorry, say that again, Miss Katia. I couldn't
So
hear
there's
very
a
well.
situation that
Yeah.
the patient is very anxious. There's
Mm.
some sort of a conflict or issue with the husband or a relative, and the husband and or relative are actually present there. So the patient is saying, "Oh, I can't breathe." Is obviously the the conflict is feeding into how the patient is feeling. That's how I understand it.
Oh, so you mean, let's see, changing here. So you mean like it could be the stressor is the husband or one of them, right? It's
Yes.
causing these symptoms. In this case, the thing that's what I mentioned earlier. We will need to somehow separate, go kind of like in a quiet area where we can gather more information from the patient. So I would kindly ask the EMS staff to take the patient away from the trigger, because it seems like the husband is being the trigger for the stress. take it take the patient away, try to calm them down in a way where, with more assuring, more acknowledging, more validation, and then to have a good eye contact with a soothing voice, more comfortable posture, where they feel the patient is actually getting the full support from the EMS. One of the things that happens, we tend, like, to be standing and then the patient is sitting. This is, I don't recommend that. It should be, we should get our knees and at least have the patient face to face. This is giving us, like, we're allowing the patient to give them the impression that, we're on the same level. I'm not dominating you by me standing and you're sitting on the floor. So these just small gestures actually can help managing anxiety. It's not just like by giving medications or getting them shifted to hospital. All these things that we said, techniques that have been proven, do help. So if I answered your question, we will go now. Dr. Ghaida would like to get on the real life scenarios. They're very interesting. We've got 15 minutes left.
All right. I'll ask.
Do you see them first,
Yeah,
Miss Katia?
I'm playing them from him,
Okay,
Yes,
presenting.
we can.
okay, perfect.
Right. Now, before going to the scenario, just briefly, I will go through, I will answer Mr. Muad. Yes, some patients, if they use the mobile phone in front of them to help them with language, they become more nervous because, I'm sorry, they become more nervous because they think we don't respect them. Now, it's very important that you tell the patient what you're about to do, right? Even if you are about to take an action or take them to the hospital, they would like to be notified with each step that we're taking. So if I told the patient that in simple body language or gestures, right? I'm pointing at the phone, that I'm opening my phone to translate and to understand you. You know, we said that you need to be empathic as much as you can. Those people are aggressive because they think that they're not seen and their case is not important and they're being neglected, right? It's the end for them. So maybe try to tell the patient what you're about to do. That will help them to not escalate their level of aggression towards you. I will go through the scenarios. There are many questions, I think, comments, but I'm not dismissing in the comment section. But I just want to go briefly through this scenarios here. Now, there is a case of a patient. His name is Muhammad. He's a 42 years old man called the EMS after leaving the gym, reporting symptoms that he believes indicates a cardiac arrest. Although his vital signs were normal, he became aggressive, accusing the staff of neglecting to help him and insisting that he would eventually go home and die. Those are the MSC for the patient, and the questions are what type of an anxiety Muhammad likely have?
Sorry, ma'am, Gaida, we could not see your slide actually. What the case which you are presenting?
Right, Miss Katya, I'm sorry for that. Just to
Oh,
buy the time, if we can
okay,
do.
I can see it. So if you stop sharing, I shall stop.
Yes, I'm sorry for that today.
Yes.
Okay. Can you see them?
Yes, now we can see.
Okay.
All right, perfect. So this is the case. The question is, you can just briefly read the case without the MSC right now, so we can have the time to
Yeah.
jump between them
If
as we can. So looking at this case, when a patient is calling the EMS after leaving the gym, thinking that they have a cardiac arrest, and the vitals were all fine and normal, they started getting aggressive and assuming that once he go home, he'll get a cardiac arrest or heart attack again, and he's being neglected. What kind of an anxiety you think he has? Miss Kathy, you can press on the three questions so they can see the questions all. So what type of an anxiety is Muhammad likely to have? You can answer in the chat as well.
or we ask someone, even if it's wrong, guys, just anything, just say it so we can discuss it.
Right? Mr. Raj said it's a panic attack. Yes, it's a form of a panic attack, but there are different type of an anxiety that Dr. Amar already highlighted, right? So this one is most likely a health anxiety, right? He is worried about his health here. Yeah? What factors might contribute to his aggressive behavior despite normal medical findings? All right, we'll go and answer that. So the factors that contributing into this situation is his thoughts as a whole, like from the beginning, this person having an health and anxiety, which usually they overestimate the threats, any injuries, anything that happens to them, the small changes in their symptoms, they're worried that they will get any of these illnesses, and that's where it contributes to maximize their sensation of anxiety. Yeah. Now I will go through the interventions later, and we can move to the next scenario, Ms. Katz. Yeah. I would like to present this scenario because it's very real, and I would like to hear your comments, the ones who's working on the triage, because mainly it's for the triage team. Whoever there are, the nurses, the psychologists, I just like to hear your feedback on that. We're gonna start picking names because we're talking about anxiety today, so we're giving you a little bit of situation anxiety here. Yeah, let's keep it real. So on your first day at work, a nurse at a National Mental Health Helpline receive a call from a patient's roommate reporting that the patient had run out of the house screaming after seeing a spider. As part of the job requirement, the nurse supervisor sat beside him, beside the responder, to monitor and evaluate the performance. This situation triggered an anxiety of both the responder and the caller. We get the situations, right? We receive calls of people are in danger, are about to do some self-harm behaviors, and we get anxious, right? This is where it's a dwelling anxiety crisis. So I would like to hear first, what anxiety do you think the responder have? The one who answered the call, what type of an anxiety he has? Is it a panic? Is it an anxiety attack? Or is it a situational anxiety? Dr. Ahmed, would you like to pick some names?
Sure, let's where we can get the list. This one. We we might ask Dral, Jessica.
Ral Jessica Lamin, if I
Yeah,
pronounce it right.
Good
There's
morning.
someone.
Situational anxiety.
Situation anxiety. Perfect. Yes,
perfect.
correct. Now there's someone already raised their hand. You can answer the second question. What type of an anxiety is the patient having? The one who ran because of a spider. Mr. Amir?
Yes.
Yes.
Go ahead.
So you can go ahead
Uh,
and answer the second question.
uh, can you repeat again? You are talking about the patient. صح?
Yes. Now, what type of an anxiety is the patient have? The one who ran away because of a spider.
So I think we can say situational anxiety. صح?
Again?
Situational anxiety due to
Try
situation.
again.
We'll give you another chance.
Mm, I think only Fatma has.
Which one? I'm sorry, your voice is cutting off.
It's due to situation. It means situational anxiety.
Situation, right?
It could be
Yeah,
situation anxiety, but most probably it's a panic attack because of a phobia.
Yes,
yeah, because the Hispanic
phobia.
after seeing a spider.
Yes.
Correct.
All right.
Okay, now we'll go to the next scenario, and then later on I will give you for the EMS team and the triage team, how would you actually intervene? What are the intervention needed,
So I
right?
would like to ask Abriel. Abriel, are you with us?
Gabriel Cortina. All right, we'll ask the question. The third scenario here is you responded to a case of an anxiety where the patient's husband carried the patient who had their eyes closed and was crying. According to the husband, the patient just received the news of her father's death. Upon the assessment, airway was clear, no chest pain, lungs sounded clear, abdominal is soft, and no vomiting, diarrhea, fever, cough, or other abnormalities. What are the key physiological and psychological symptoms present in this case? Now that's very easy.
Can we, Mariam? Well, this is with us, right? Angelica.
Hi, good morning, doctor.
Good morning. Can you just give us what do you think physiological or psychological?
For the psychological,
Mm-hmm.
since the patient received a news that her father regarding her father's death,
Yes. So what symptoms can she have?
um, symptoms she's crying, her eyes is closed,
Yeah.
and extreme sadness.
Okay. Is that
Thank you.
satisfying?
Yeah,
Yes,
thank you. Thank you for that. All right. We'll go through the fourth scenario. All right. This is a very interesting case, actually. This is a friend of mine. There is EMS responded to a routine call about a patient who had twisted her ankle while on her morning run. The patient appeared stable until she was placed inside the ambulance for transport to the hospital. So the patient was fine mentally until she was placed inside the ambulance. There where she felt anxious. What type of an anxiety mostly is that?
I would like to hear from Shafi Shamsuddin. Shamsuddin?
Miss Colette is raising her hand.
Sure.
Yes, Miss Colette.
Yes, hi. I think she's having like a panic episode because of the claustrophobia issue. She's having a difficulty with the short, small space of the ambulance.
Perfect. Thank you very much.
Anyone else? Mr. Mu'adh?
We can move to the, we will move to the last question, the last scenario. The fifth scenario is John, an 18 years old male. He called the National Mental Health Line expressing an anxiety triggered by the fireworks. He reported experiencing racing heartbeat, shivering, and feeling overstimulated. No other complaints from the patient. A quick mental statement was done. How do environmental triggers contribute to his anxiety?
Would like to hear from people to participate, please. Muhammad Maruni, Mr. Muhammad Maruni.
All right. So this is a situation in anxiety because fireworks does not occur in everyday like and on daily basis, right? The sound of fireworks, the lightning could be triggering for the patient. Those are the environmental factors, and it's could be reminding the patient of loud voices, an early traumatic experience he witnessed before, right? I wanted actually to go into these scenarios to explain actually the roots, the cognitive side, and the behavioral manifestation and the emotional part of those scenarios of each individual, and how we can tailor better intervention for acute incidents like these, right? So we spoke about the differences of breathing technique, and we said that not all of them are actually fit for all sizes. So I wanted actually to see how we can allocate or use different techniques in different situation. Unfortunately, the time is actually running out. We have 3 minutes. So I will ask Miss, we're in from the scenarios here, and I'll ask you all and Miss Katia for sure, Mr. Raj, if you do have any comments about these slides or anything that you would like us to say before we end.
This is really very nice presentation, ma'am. It has been covered in the pre-hospital settings context. Really, this is very, very good actually. But what we do it, we don't differentiate the types of anxiety here. We just generalize it. It's case of anxiety here. But the paramedics should have the knowledge of how to differentiate the anxiety and what is the risk factors, how to manage it. It's well organized program for both of you. It is really good informative to the EMS staff, I believe.
Yeah.
Thank you.
Thank you
Yeah.
very much. The only message that I can give always, always keep in mind to rule out medical conditions very, very, very importantly, and to gather collateral information as much as you can. That would help us a lot for our impression when we receive the patients in ED. That would be most beneficial. And you guys do always great job. We really appreciate everything you do when we thank you all.
Thank you, everyone.
Thank
Thank you
you.
for showing up.
Right. Dr. Omar, Nikita, thank you so much for taking the time. If I may ask everyone to please take a couple of minutes and complete the course evaluation link that Rajkumar kindly just posted, and I think he will post now the timeout, which everyone needs to remember to complete for the CPD points. But I really hope it has been a beneficial session. There are many thank you comments in the chat. I thought it was really interesting. I love the fact how you worked so well together. I know you prepared together for this as well. I think it was very relevant for both contexts, the helpline and EMS, and the use of examples really kind of brought a message home. So I hope that others felt the same way. But really appreciate if you give us brief feedback. Um, and I'm going to say again that as we have only started our joint CPD program, we really want to hear from everyone because obviously we're matching two quite different groups together. So much appreciated.
Thank
Um,
you, Katya.
Thank you.
really, really appreciate it. Well done, guys. So I will
Thank
send
you.
you your certificates today as a
Um,
thank you. That's
all
about it.
right.
Thank you.
All right.
I'll buy you coffee when you come to Bar
Okay.
Sour.
Now we will be more anxious. We're trying to avoid being anxious. Okay.
uh,
Enjoy everyone. Happy Wednesday and happy and Ramadan Kareem in advance for everyone. Saturday is Ramadan.
Ramadan Kareem, everyone.
Thank
Our
you.
next
Thank you.
session will be 13th of March and we'll be focusing on supporting good sleep. I know insomnia and sleeping issues are a real issue for us as healthcare professionals with the shift working and so on. So I look forward to Miss Divya's webinar on the 13th of March. And as always, thank you so much, Raj Kumar and Colette, for your support in getting organized and having smooth running of the webinars. But happy
Thank you.
Wednesday, everyone. Ramadan
Thank you.
Kareem,
All
and
right.
take
Take
care.
care. Bye bye.
Okay,
Take care. Bye
bye.
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 Thank you. Bye.